Hi, I'm Dave Fornell, a digital editor with Cardiovascular Business, and I have with me Peter Fail. He is the co-director of the Structural Heart Program at Terrebonne General Medical Center in Houma, Louisiana. He's also served as a principal investigator or sub-investigator for several clinical trials for new devices, and most recently that included interatrial shunt devices used for heart failure. And you presented in a session earlier today about these types of devices, and I wanted to find out where they are going and what the data has been up to this point.
Well, we were part of the Corvia trial, which was actually implanting a shunt implanting a device into the atrial septum to allow the thought to unloading the left atrium into the right atrium. And what was interesting is that although it was reported as a neutral trial where there was no benefit, there really was a subgroup analysis that showed that there was a group of patients that benefited. And I think, one of the nice parts about that trial is that it gave all the other devices or therapies that are utilizing a shunt as a mode of treatment, which patient identify.
So with the Corvia device, is there an advantage to having a stent structure? Or because some of the technologies that they're looking at now, they've actually done away with the stent structure.
Right. So the Alleviant group has developed a catheter that basically will excise, if you will, a piece of tissue out of the atrial septum. And they do it both with mechanical compression as well as RF energy. And when we looked at preclinical animal models, it has a very well circumscribed, healed area. What we don't know is there going to be a mechanical advantage to a device that it will stay open, or is this Alleviant catheter going to be able to stay open for a period of time? That's time will tell.
The device technology trials to date, has there been a signal in some of the other trials that's showing that this is the way to go? I know there's a presentation
Yes,
at
exactly.
ECC.
So I think there is the problem I think that we have with diastolic heart failure is really sort of the heterogeneity of it. And I think one of the advantages of a neutral trial in subgroup analysis showing that there is a group of people that will benefit from it, that actually got much better. In sort of a infantile idea, if you will, the realization is that when your pulmonary vasculature is maxed out, if you will, it cannot tolerate that extra volume, no matter how small it is, coming from the left atrium into the right atrium or the right circuit. And that was the people that didn't do well, okay? So it looks like that if your pulmonary vascular resistance is in the moderate range or low, and we have a number that we've identified, if it's below that at peak exercise, then apparently you can tolerate that level of increased flow and there will do improvement.
So the research really should be directed at maybe figuring out what that patient selection is.
To try to really define that patient population that will benefit. Obviously, the worst thing we do is to make patients worse. If it's not necessarily worse, but basically they don't get any better, it's of no value to them. And so we really want to find that patient population that we can identify them based on both phenotypic identification and then invasive hemodynamic monitoring, and saying this group of patients will benefit from this device or therapy.
And can you speak maybe just overall with the world of heart failure? There's a lot of interest right now in hospitals trying to reduce readmissions.
Sure.
and basically keep these patients out of the hospitals.
Right.
So how is a device like this potentially going to impact things?
Well, when you look at some of the studies, diastolic heart failure is actually outpacing systolic heart failure fairly dramatically. And I saw a study, it's several years old though, that probably 60% of our heart failure admissions to the hospital are going to be diastolic heart failure. I think one of the biggest problems we have with diastolic heart failure in the pre-hospitalization is identifying that person. We have some ideas phenotypically what they should look like: hypertensive, maybe overweight, maybe metabolic syndrome, diabetic, et cetera. There's a few kind of caveats, but a lot of times when you think about this person, they're the person that comes to you that maybe freely would admit, doc, I put on a little weight and I'm a little bit short of breath. The trouble is that when we actually see them in the hospital and then we go back and look at their record over the past maybe year, we'll see they've been complaining of shortness of breath for a while. So unfortunately for diastolic heart failure, there's no great big red flag that says this is heart failure. And what I always impress on my colleagues is that, if this person came in complaining of shortness of breath and you looked at an ultrasound and the echo said their ejection fraction was 25%, you would automatically say it's heart failure. But if you look at the echo and it says their ejection fraction is 60%, you go, you're overweight. And that's where sort of the disconnect is, where we're not really able to identify people clearly quickly enough. If it's prevalent as we see it, you would think that we'd be seeing a lot more of these patients before they hit the hospital. So unfortunately, it's not until they hit the hospital, they have elevated biomarkers, they have chest x-rays that are whited out, and the normal, relatively normal echo, oh, you have diastolic heart failure.
So do you think these trials will help add additional information to maybe be a little bit more proactive rather than reactive in heart failure?
Well, I do think so. And I think one of the things in everything in cardiology is once we sort of identify that and there starts to be the buzz about it, then people become a little bit more acutely aware of it. And I think that's really what some of these trials have been able to do. And so heart failure clinics now are seeing much more diastolic heart failure as people are becoming aware that, yes, this is a true entity, and maybe when they are sitting in my office complaining of shortness of breath, maybe it's heart failure and it's not just that they're overweight.
Great. Well, thank you very much for your time.
My pleasure. Thank you.